Okay, chapter 2 has a ton of information in it, and I don't want to get too bogged down in it, but I want to sort of hit the high points and talk about how it applies to therapy. I sort of resigned myself to the fact that the lectures this summer are going to be, well, hopefully not too long, but not too short either, because there's a lot of information. So hopefully it's nice wherever you are, and you can grab your headphones and head out and go someplace nice and listen to the lecture out there. Or, enjoy the lovely indoors, whatever works best for you. So, the first part of chapter 2 talks about fluid imbalance, and it's a pretty huge subject. Water is a major component of the body. So when you look at this graphic, I think is really interesting. It's not from the book, it's just right here. But it talks about the percent of different organs that's made up of water. Lots of our body is made up of water, which is, kind of interesting. It's found within the cells and outside the cells. It's essential to homeostasis because the water part of it functions in maintaining a relatively constant and favorable environment for our cells to function in. It's the medium within which metabolic reactions and other processes take place. It's the transportation system for nutrients and waste products and really anything that needs to be transported in our body. And it facilitates movements of body parts. So if our joints or our lungs or our heart were really stiff and not fluid, we wouldn't have that movement that we have that's so essential to life. So I think it's really kind of critical as in physical therapy, movement is our thing. That's what we're all about. We want to encourage people to move and facilitate people's moving to avoid complications. So at the end of this quarter, we're going to talk about the complications of immobility. And without water, we're going to have immobility. So it's a big important thing. And we talked a little bit last quarter about the components of connective tissues, the ground substance that the connective tissues are embedded in, and that is largely composed of water as well. And when our tendons and ligaments get dehydrated, they are more susceptible to injury and damage. So water is hugely important, and the fluid balance in our body is hugely important as well. So about 60% of an adult's body weight is water. About 70% of an infant's body weight is water. So females tend to have a higher percentage of fatty tissue than males, darn it. And so we have lower water content. Older adults and obese persons also have lower proportions of water. There's in table 2.1 in the book, there's a little note at the bottom where it says in elderly women, water content is reduced to approximately 45% of body weight. So that's significantly reduced. The upshot of that is that individuals with less fluid reserve are more likely to be adversely affected by any fluid or electrolyte imbalance. So if you have more fluid reserve, you can take up the slack a little more easily. And if you have less fluid reserve, you're more susceptible to fluid and electrolyte imbalances. And I've actually seen the proof of this in acute care in the hospital, where elderly women are frequently the ones that have electrolyte imbalances that are seriously affecting their health and mobility. So we have our fluid compartments in the body. The fluid is distributed between these different compartments. We have the intracellular compartment, or ICF, intracellular fluid, which is the fluid inside the cells. And that is where everything happens. It's, ribosomes making RNA, making proteins, dealing with everything we need to deal with, our cellular metabolism. The extracellular compartment contains extracellular fluid, or ECF. And extracellular fluid includes intravascular fluid, or IVF, interstitial fluid, which is the fluid between the cells, or ISF, cerebrospinal fluid, which we'll talk about a considerable amount in neuro next winter, CSF. And then there are what we call transcellular fluids, which they're fluids that are present in various secretions, fluid in the pericardial cavity or the synovial cavities of the joints. So last quarter in kinesiology, we talked about the synovial cavities and how the synovial membrane creates synovial fluid, which lubricates and gives nutrients to the joints. Well, there's some fluid. There's some fluid in the body. So obviously, it's a huge, big deal. The intake and output of water is pretty important. The amount of water entering the body should about equal the amount of water leaving the body. There we're maintaining homeostasis again. So we get most of our fluid intake from the ingestions of solid food or fluids, and most of our fluid loss is through urine and feces, with some additional loss through perspiration and exhaled air. So there is a table in the book on page 15, table 2.2 of sources and losses of water, and it's basically a lot. It does it in milliliters or cubic centimeters, and milliliters are the same thing. So our intake of liquids accounts for about 1,200 milliliters of our intake per day. Solid food, about 1,000. So we get a lot of our water from solid food as well. And 300 milliliters from cellular metabolism. So, if you remember from chemistry, where in aerobic respiration, we burn hydrocarbons in air and we form water and carbon dioxide. So, or burn hydrocarbons in oxygen, form water and carbon dioxide. So that cellular metabolism produces some of our water intake, basically. And for a total of 2,500 milliliters. We lose about 1,400 milliliters in urine, about 200 in feces, and then 400 and 500 through our lungs and our skin, adding up to the same amount, 2,500 milliliters. So anything that affects any of those things, so say that you're nauseated and you can't ingest food or fluids, that's going to affect your fluid intake. Say that you have a problem with breathing or perspiration or urinating or defecating, that's going to affect your output of water. So that's going to affect your fluid balance. This is the table from the book that I was talking about. I guess I could have switched the slide. So we balance, we have some cellular and body mechanisms to balance our water and electrolytes. Thirst is one of them. We have a bunch of receptors, neural receptors, which again we will talk way more about in neuro next winter. But we have osmoreceptors in the hypothalamus that tell us when we're thirsty. So it's the little reminder, like, hey, you better drink water. We have a hormone called antidiuretic hormone, which affects reabsorption of water from the kidney tubules. I'm just drinking some water just to... doesn't this slide make you want to drink water? Anyway, aldosterone is another hormone which is involved in the reabsorption of sodium and water. The atrial natriuretic peptide and T-type natriuretic peptide are proteins, basically, but that act as hormones that are synthesized by myocardial cells that regulate fluid, sodium, and potassium levels. So we have all these different systems to help regulate that. The water or fluid circulates through the body via filtration and osmosis. And it's dependent on those permeable cell membranes that we have. So water moves between compartments via hydrostatic pressure and osmotic pressure. So we can think of hydrostatic pressure as being a pushing pressure. It's pushing water from one place to another, from one compartment to another. And osmotic pressure is being a pulling pressure. It's pulling water into a vessel or into another compartment. So we will talk more about this hydrostatic pressure and osmotic pressure, and about edema. In fall quarter, in modalities, we are going to talk about lymphedema and treatments for edema and do compression wrapping in the lab. Store this little nut of information away, and we will revisit it next quarter. So when we have an excess of fluid, it's called edema. It's another word for swelling. It's an excessive amount of fluid in the interstitial compartment. So it's outside the vessels and outside the cells. Edema causes swelling or enlargement of tissue. So no matter what PT setting you work in, whether you work in outpatient, inpatient, it doesn't matter, you're going to see edema and you're going to have to deal with it. So edema may be localized, like you turn your ankle and it swells up. That's localized edema. It may be throughout the body, like systemic edema with congestive heart failure, or just immobility can cause edema. When you have edema, it's compressing all the structures in the area, and it may impair tissue perfusion. And perfusion is the travel of oxygenated fluid, oxygen basically, through the area. So this is important. We really need to have tissue perfusion because we need that for cellular, to bring nutrients and to take up the waste products of cellular metabolism. Excess fluid or edema may trap drugs in the interstitial fluid because it changes our hydrostatic pressure and our osmotic pressure. We might have medications and drugs in our system that get trapped in the interstitial fluid, where basically they are going to do you no good. And they can actually cause harm. So edema can be a fairly serious issue. So there are lots of different things that can cause edema. Increased capillary hydrostatic pressure caused by higher blood pressure or increased blood volume can be a cause of edema. It forces increased fluid out of the capillaries and into the tissue. So you have that higher blood pressure or increased blood volume that's basically increasing the pushing force, pushing the fluid out of the capillaries into the tissue. That is the cause of pulmonary edema, so swelling in the lungs, which that's a really serious issue. It interferes with your vital function. Edema can also be caused by loss of plasma proteins, particularly albumin, which is the most common dissolved protein in our body fluids. When we have less albumin, it results in decreased plasma osmotic pressure. So the water isn't getting pulled from the interstitial space into the vessels. So you can think of pulling and pushing. If there's something wrong with either the pulling or the pushing, then it just doesn't work. So edema can also be caused by obstruction of lymphatic circulation, causing localized edema. So you can get excessive fluid and protein that aren't returned to general circulation because of obstructed lymphatics. And so lymphatics can be obstructed by lots of different things, trauma, disease, tumors, all sorts of things, infection, damaging a lymph node. So there can be a lot of reasons for obstruction of the lymphatic circulation. Some people have congenital edema where the lymph system just isn't normal. So edema can also be caused by increased capillary permeability. It usually causes localized edema, and it can result from a localized inflammatory response or infection, and we're going to talk way more about those in Chapter 5. It can be caused by histamines and other chemical mediators that are released by the body to increase capillary permeability. And it's one of our natural responses of our body to a change in homeostasis. So we are going to talk about that a lot in Chapter 5. Edema can also result from some bacterial toxins or large burn wounds, and that results in less localized, more widespread edema. So the effects of edema are swelling in the local area. The skin can either be pale or red in color, depending on what's going on. If you have increased capillary permeability, it's probably red. If you have restriction of circulation, it's probably pale, but any of those things can happen. Pitting edema, and this is a picture of pitting edema from the book. There is a presence of excess fluid in the interstitial space, and you can sort of squash the fluid when you put pressure with your fingers, and a depression or pit remains when the finger is removed. And there's actually a system for grading pitting edema by how long it stays and how deep it is. We'll talk about that more when we talk about lymphedema in the fall quarter. Edema can cause an increase in body weight with generalized edema because you have more fluid. Fluid weighs something, and it can cause an increase in body weight. So a lot of times in an inpatient setting or even an outpatient, one of the ways that they're monitoring whether people's edema is decreasing is they weigh people. So that's a pretty good measurement of whether your edema is increasing or decreasing. Pain can certainly occur if edema exerts pressure on nerves locally. You can have headaches with cerebral edema. Cerebral edema is a very dangerous type of edema because it puts pressure on the brain. And it can also stretch the capsule and organs like the kidney or liver, and that can cause referred pain. Edema can cause functional impairment because it restricts the range of joint movement. It can, pulmonary edema can reduce vital capacity. You can't get as much oxygen in. And it can impair the diastole, which is the relaxation and the filling of the heart. You can imagine if you have excess fluid in the pericardial sac, there is not room for the heart to expand and fill with blood. And then that's going to affect everything down the line. So depending on where your edema is, it can be a serious situation. It can also cause impaired arterial circulation, which can cause ischemia leading to tissue breakdown. So the effects of edema can be wide-ranging and affect everything down the line. It can also cause dental complications. If somebody wears dentures, they have swelling in their mouth. The dentures are not going to fit well. It's going to make it difficult for them to eat. It's difficult to take accurate impressions, dental impressions, if you have edema. If you have edema in your skin, it's more susceptible to tissue breakdown from pressure. So there are a lot of effects and complications. So the opposite of edema that's fluid excess, is fluid deficit, which is dehydration. And dehydration is insufficient body fluid due to either inadequate intake, excessive loss of fluid, or a combination of the two. Just like edema is often measured by change in body weight, fluid loss is the other side of the coin, and it's often measured by a change in body weight. Dehydration is more serious in infants and older adults because they have less fluid reserve. We talked about that in an earlier slide. Water loss, unfortunately, can also be accompanied by loss of electrolytes and proteins. For example, when somebody has diarrhea, they're losing a significant amount of water, electrolytes, and proteins in their feces. And so it can cause serious problems. It can actually kill you if it goes untreated. So you can end up with hypovolemia, which is the vascular compartment has less volume, less blood volume, and it can affect the heart, brain, and kidneys. So it's a huge, big deal, dehydration. So causes of dehydration, of course, vomiting and diarrhea can cause dehydration because you're getting rid of all your fluids pretty quickly, and you're probably not able to take any in at that point. That's why they will right away do interventions, IV fluids, anti-nausea medications. They have injections and suppositories for the anti-nausea medications because vomiting and diarrhea can be life-threatening if you don't intervene. Excessive sweating with loss of sodium and water. So like this guy in the picture, he's out there running in the hot, hot sun, and he's losing sodium and water, and he could be getting dehydrated. Diabetic ketoacidosis can cause loss of fluids, electrolytes, and glucose in the urine. So we're losing all that stuff through our urine. Insufficient water intake in older adults or in unconscious persons, like somebody's in the ICU, they have to make sure they're keeping their fluid up. As we age, our osmoreceptors in the hypothalamus become less sensitive, and we do not sense thirst as much. So it's very common that older adults will have insufficient water intake. The other issue in older adults, if they have decreased mobility, a lot of times they'll say, oh, I don't want to drink water. They will consciously choose not to drink water because they don't want to have to get up and go to the bathroom, because that's harder for them. So it's really important anytime you're working with older adults, particularly in an inpatient setting, but you can talk to them about it in an outpatient setting as well, that you encourage water intake. I'm always, when I work in outpatient, when I'm working in the outpatient setting, not just with older adults, but with everybody, I always offer people water. I always say, okay, we're going to take a break. Do you want to drink water? And a lot of times they go, oh, yeah, thanks. And sometimes they go, oh, no, thank you. And I go, really? You sure? We're not doing anything else. Unless I know that they shouldn't be taking in extra fluids. Use of concentrated formula in infants can suck the water right out of their body too, because the body fluids are going to rehydrate the concentrated formula. So seems like a bad idea. So dehydration, it can cause dry mucous membranes in the mouth. So a lot of medications also cause that. So that's why usually my outpatients are just dying to have that glass of water. It can cause decreased skin turgor or elasticity. Some people say turgor, some people say turgor. You can say however you want. So the picture here is a test for skin turgor, where you pinch the skin on the back of your hand, and if it stays in place, you're dehydrated. I'll never forget when I was a freshman in college, I had a biology instructor who was must have been talking about dehydration. I don't remember specifically, but I do remember that he said if you go out drinking, the next day you'll have decreased skin turgor because your body's dehydrated. I don't remember ever checking that, but for some reason that stuck in my mind. So lower blood pressure, weak pulse, and fatigue can also be effects of dehydration. It makes sense. With lower blood pressure, you have lower blood volume. You're going to have lower blood pressure and a weak pulse. And then the oxygen's not getting where it needs to go, and you have fatigue. It causes increased hematocrit, and hematocrit is the percentage of red blood cells in your blood. The hematocrit is increased because you have less water and more red blood cells. So that's why it causes that. At the extreme end of dehydration, it can cause decreased mental function, confusion, and even loss of consciousness. So dehydration can be a serious issue. This shows someone testing a patient for dehydration. Often, instead of testing on the hand, like that other picture, you test right below the clavicle. Because if their trunk is dehydrated, you know that it's progressed. So the manifestations: decreased skin turgor, dry mucous membranes, sunken eyes. Sometimes when you see someone who's really dehydrated, it's very noticeable, actually. Their eyes do look sunken and dark. Sunken fontanelles in an infant. Some of these we've already talked about. Lower blood pressure and rapid weak pulse, increased hematocrit, increased temperature because the cooling effects of the fluid aren't there, decreasing levels of consciousness, and low urine volume. So a lot of times when you're working in inpatient, you'll in the bathroom in the patient's room, there'll be a little container. They're keeping track of their urine output volume. There'll be a little graduated cylinder that if you take the person to the bathroom, they have to pee in that. So nursing can keep track of their urine volume. And then you can test the specific gravity of urine. And if someone's dehydrated, it'll show up as high specific gravity. That's done in the lab. So our body is going to attempt to compensate for fluid loss by increasing our thirst, increasing our heart rate to pump around that low blood volume, constriction of cutaneous blood vessels, so we're not sending all the blood to the skin, we're sending it to the vital organs, and producing less urine or concentrating the urine. There is a phenomenon that's called third spacing of fluid, where fluid shifts out of the blood into a body cavity or tissue, and it gets trapped out there. It can no longer re-enter the vascular compartment. So if there's high osmotic pressure of interstitial fluid, as in burns, third spacing can happen. If there's severely increased capillary permeability, as in some infections with gram-negative bacteria, you can get third spacing as well. And this can be a life-threatening, shock-inducing, low blood volume issue. So there's no way, once it gets out of the correct spaces, once it gets into those third spaces, there's no way for it to get back out and into general circulation. So it's a pretty serious issue.